We have excellent speakers this morning. We have Susan Awad, Mark Sklansky, Shabnam Pavandi, and we're going to hear a wonderful series of different cardiac pathology in the fetus from them. Over to you, Sasha. Oh, one more little thing. If I can, let me just show you the channel. All of this stuff is recorded and will be available for you to review. It's at https://bit.ly/again Congenital Heart Academy channel. Thank you very much.
Rima, when you want.
Hello, everybody. And again, welcome to the second webinar on the Fetal Cardiology series, supervised by the Congenital Heart Academy. I just want to tell you that we're going to have a monthly webinar in the last week of every month on the Thursdays, and it's going to be on 4 p.m. Rome time. If you miss this talk, you will find all the Congenital Heart Academy webinars on the YouTube, on the Congenital Heart Academy channel. Don't forget to subscribe. Today, we're going to have three eminent speakers, and we're going to talk in three different topics. I'd like to introduce the first speaker, and Dr. Shabnam. She's Associate Professor in Pediatrics and Associate Director of Fetal Program at UCSF. Her main interest, or one of her main interests in research, is fetal markers of neurodevelopmental outcome in children with congenital heart disease. Welcome, Shabnam. Could you please come in?
Hi, Rima. Thank you so much. And thank you to you and to the Congenital Heart Academy for inviting me to speak in the fetal series, and in particular, allowing us to share some of our work from our fetal heart and brain research program here at UCSF, where we have really been focused on understanding fetal markers of neurodevelopmental outcome in congenital heart disease. So as we all know, human cardiac development is largely completed by the end of the first trimester. And this is in contrast to human brain development that extends over a much longer period of time, with morphologic events occurring in the first 2 trimesters, and then a refinement of connections and myelination that begins in the 3rd trimester and extends into the early postnatal period. And interestingly, the 3rd trimester of gestation is marked by a period of accelerated brain growth, which consists of organization of the cerebral cortex, increased cerebral metabolism, and an increased demand for oxygen. And so the heart responds to this accelerated phase of brain growth by increasing blood flow to the brain, such that in the 3rd trimester of fetal life, approximately 25% of the cardiac output is directed towards the brain. And this is based on fetal lamb models from Dr. Rudolph, demonstrating the changes in distribution of cardiac output across gestation. So clearly there's a strong relationship between the heart and the brain that begins in utero, and we believe that, at least in part, that heart-brain interplay prenatally influences neurodevelopmental challenges or abnormalities that patients with congenital heart disease face. The increased risk of acquired brain injury after birth, as well as abnormal brain development, much of which begins actually before birth, which we'll review. So for this particular talk, I'm going to focus on how advanced fetal imaging has helped us understand this heart-brain relationship in utero, to better understand fetal brain development in the context of congenital heart disease, Second, to understand physiologic mechanisms that may be responsible for delays in brain development. And then more recently, whether some of these advanced fetal imaging techniques can help us predict neurodevelopmental outcomes in patients with congenital heart disease before birth. So this is a fetal echo series. So we should say that we've learned a lot from fetal echo when it comes to the brain. In particular, looking at patterns of the cerebral Doppler patterns in the cerebral vasculature, specifically the middle cerebral artery. And this was originally described in the context of placental insufficiency and growth restriction, where in the setting of an overall hypoxemic state, there was an observation that the middle cerebral artery was, quote, brain sparing, with evidence of a lower resistance or impedance within the cerebral vasculature, also denoted by the pulsatility index, which is lower than what we would normally expect. And this is thought to be a compensatory mechanism in response to the overall hypoxemic state in the setting of growth restriction. And this same pattern has been seen in other forms of congenital heart disease, including hypoplastic left heart syndrome, where there is both obstruction to flow to the brain, as well as some degree of decreased oxygen delivery to the brain. And so we see this same pattern of, quote, brain sparing in the context of specific forms of congenital heart disease as well. And I think the literature is a little varied in terms of the predictive value of this observation when it comes to neurodevelopmental outcome. Some studies suggest that the more brain sparing there is, that it may be protective and neurodevelopmental outcomes are better, whereas other papers have suggested that this is a sign of worse neurodevelopmental outcome after birth. So it hasn't really turned out to be a really reliable predictive measure for predicting outcome in the context of congenital heart disease. Where we've learned the most about the brain is really MRI, and utilizing this other imaging modality to really get detailed information about brain structure as well as brain function. Kathy Limperopoulos and her group were the first to publish their findings on fetal brain MRI findings in the context of congenital heart disease. And they demonstrated that there was fetal onset of delayed brain development. And what you could see here is they measured total brain volume, which is a much more sensitive measure than biparietal diameter or head circumference that we measure on ultrasound, because it's just measuring the actual brain matter and the brain volume. And what they showed is that fetuses with congenital heart disease have a significantly lower total brain volume, depicted by this blue line here, compared to fetuses without congenital heart disease. And that discrepancy was seen beginning in the early third trimester. So this really follows the pattern of what we know about normal brain development in that period of rapid brain growth in the third trimester. The fetus with congenital heart disease doesn't seem to be able to keep up. They've also gone on to look at other smaller regions within the brain to show that it's not just global volume that is delayed in congenital heart disease beginning in utero, but that other regions of the brain, including the developing white matter, as well as the cortical gray matter, grow at a much slower rate in congenital heart disease compared to the normal fetus. And then they also looked at other measures of brain development, specifically metabolic brain development, which essentially measures levels of important metabolites within the brain. And this is sort of a voxel-based approach where you take a particular region of the brain and look at these measures of important metabolites, including N-acetyl aspartate to choline ratio, which the higher that value is, the more mature the brain is. And what they showed was that in fetuses with congenital heart disease, they had a lower N-acetyl aspartate to choline ratio as compared to controls. And again, that discrepancy began in the early third trimester between the two groups. Interestingly, what they also demonstrated was that fetuses that had hypoplastic left heart syndrome with lack of antegrade flow in the aorta, these are the fetuses here with the solid blue dots, had the lowest levels of this important metabolite. And this sort of intuitively makes sense, given that these fetuses probably have the most degree of impairment to blood flow and oxygenation to the brain. And they also detected cerebral lactate, which we shouldn't see at all in the brain, but it was detected in 20% of the cases, including 5 of the fetuses with hypoplastic left heart syndrome and 2 of the fetuses with transposition of the great arteries. So these observations then led to a sort of second phase in this research, which was the question of what is the physiologic mechanism of delayed brain development in utero. And I think this is critical because as cardiologists, we know that all these different forms of congenital heart disease are very physiologically different. So a fetus with transposition, for example, has a very different complement of blood flow and oxygen and nutrient delivery to the brain compared to a fetus with hypoplastic left heart syndrome that has obstruction to antegrade flow and brain blood flow is received in a retrograde fashion, or as compared to tetralogy of Fallot, where there is varying degrees of pulmonary outflow tract obstruction. So, in terms of trying to get to the point of improving brain development, it's important to understand the physiologic mechanisms so we can know where we need to intervene to optimize brain development. And this phase of research has really been spearheaded by Mike Seed and his group at the University of Toronto at Sick Kids, where they have used innovative techniques to perform cardiovascular MRI in the fetus. And this can be extremely challenging, as you can imagine, because not only are you dealing with a fetus who may be moving, as well as maternal breathing during the MRI that can lead to significant motion artifact, but you're trying to measure physiology in very small vessels in the fetus. And so in this first publication, they reported their findings of phase contrast cardiovascular MRI, which essentially allows for blood flow quantification within a vessel of interest by integrating velocities from voxels comprising the cross-sectional area of that vessel. Now, the other challenging part about cardiovascular MRI, as opposed to doing this after birth, is that it requires cardiac triggering and gating to the fetal heart rate, which at the time they used a technique called metric optimized gating, which retrospectively gated the images to the fetal heart rate. Currently, there are other techniques that have come out that allow real-time gating to the fetal heart rate for cardiovascular MRI, but this also demonstrates the innovation for this type of advanced imaging that occurs in the fetus. So in this first study that they published, they demonstrated basically flows in various locations of the fetal heart as a percentage of the combined cardiac output. So very similar to diagrams that we've seen from Dr. Rudolph. And I have to say that most of their findings were very similar to the original findings that were described by Dr. Rudolph in the fetal lamb model many, many years ago. And when it came to specifically understanding cerebral blood flow, they looked at the superior vena cava as a surrogate for cerebral blood flow, namely because, as you can imagine, in the fetus with, let's say, hypoplastic left heart syndrome, it would be nearly impossible to measure the amount of flow going across a tiny ascending aorta. So as a result, they used the SVC as a surrogate for cerebral blood flow. And you can see here that, interestingly, on average, SVC flow was similar between the normal fetus and the fetus with hypoplastic left heart syndrome. But they also went on to say that there was significant variation in SVC flow among the fetuses with left-sided lesions. And this was a pretty heterogeneous group, which consisted of fetuses with hypoplastic left heart syndrome on one hand of the spectrum, but also fetuses with coarctation of the aorta that had antegrade flow to the brain. So it's possible that those fetuses with more obstruction to antegrade blood flow to the brain had even lower SVC flow as compared to the fetuses that, let's say, just had coarctation of the aorta. And then they followed up their findings with further innovation by, in addition to being able to measure flow in the fetal heart, by utilizing magnetic resonance oximetry to essentially measure oxygenation within different regions of the heart and different regions of the fetus. And so here what we can see is they looked at, they used a technique called T2 mapping, and looking at the umbilical vein and the umbilical artery just to get a sense of overall oxygen delivery to the fetus. They showed that in the fetus with congenital heart disease, they had a much significantly lower level of oxygen delivery and oxygen consumption as compared to controls, on the order of a 17% reduction in both oxygen delivery and oxygen consumption. And then they specifically did these measurements, again, using the superior vena cava to estimate cerebral oxygen delivery and cerebral oxygen consumption. And again, this does require some assumptions, in terms of what is assuming the hemoglobin in the fetus, because these are all non-invasive techniques to actually get to these values. But what they did show was that cerebral oxygen delivery and cerebral oxygen consumption was significantly lower in the fetus with congenital heart disease compared to controls. And the other thing to note is that this was, again, a very heterogeneous group of fetuses with varying degrees of varying types of cardiovascular physiology, including right-sided obstructive disease, hypoplastic left heart syndrome, and transposition of the great arteries. They also were able to show, by simultaneously performing a fetal brain MRI, they did show a direct correlation between brain size and cerebral oxygen consumption in the third trimester of fetal life. And so this is an interesting observation. I think it's hard to know which one is the chicken and which one is the egg here. Is it that the brain is small and therefore the cerebral oxygen consumption is lower? Or is it that cerebral oxygen consumption is low and the brain doesn't grow as well? So this really led to some interesting questions that have risen from this really landmark paper that was published in 2015. So here at UCSF, we've employed a technique that is a little bit different from what I've described so far. And that is that we are studying an MRI modality to help us measure tissue oxygenation. And T2 star MRI is a sequence, an MRI sequence that has been used in various disease states, including in iron overload, as well as looking at the brain postnatally, and has been started to be looked at prenatally as well. And the basic how T2 star MRI basically works is that it's a measure of relative levels of deoxyhemoglobin in the tissue of interest. So in this case, we're interested in the brain. and measuring, and it gives you sort of a global sense of oxygenation within that tissue of interest. And basically, within a tissue of interest, the deoxyhemoglobin content is inversely related to the T2 star signal decay. So for example, here you can see these are two different fetuses. One where you can see the T2 star decay time, or the amount of time it takes for this sequence to decay, is shorter at 90 milliseconds, and that would suggest that there is a higher deoxyhemoglobin content and thus lower cerebral tissue oxygenation. And so the reason why we employed this particular technique is that it turns out it's a relatively quick sequence that can be performed in the fetus. It takes about 5 minutes. And so it does help us get around some of these issues of motion artifact due to fetal movement. And it just gives us sort of a global sense of tissue oxygenation that potentially can be used as a predictive tool for what we might expect postnatally. So we just recently published some of our first findings using this technique. And this was really just an initial paper to show that this technique works, but also to show that similar to other studies, that cerebral tissue oxygenation is lower in congenital heart disease. So we can see in this figure here, the fetus with congenital heart disease has a much faster rate of decay in this T2 star signal compared to the control fetus. And we also had the opportunity to see if different physiologies, different forms of congenital heart disease had different degrees of cerebral tissue oxygenation. And we actually found that in detransposition of the great arteries and left-sided obstructive lesions, most of which had hypoplastic left heart syndrome, they tended to have similar degrees of cerebral tissue oxygenation, and both were significantly lower compared to the control fetus. So currently we're working on all of these fetuses are going on to get postnatal brain MRIs, as well as follow-up neurodevelopmental testing to see if we can use this particular technique to help us predict the risk of brain injury after birth, risk of ongoing brain immaturity, as well as adverse neurodevelopmental outcomes. So I think most people want to know, well, these are really interesting observations and are really innovative, but can these tools help us predict outcome? And that's certainly one of our interests here. And this particular study that we published a few months ago with our collaborators in Toronto with Mike Seed and Stephen Miller was a multi-center study that we were trying to somewhat answer this question. And we performed longitudinal brain MRI beginning in utero in fetuses with hypoplastic left heart syndrome and detransposition of the great arteries. And each participant had an MRI in the 3rd trimester of fetal life, depicted on the left hand of this figure, followed by a preoperative brain MRI after birth, or a neonatal MRI. So even before these babies are going to the operating room, they had an MRI done. And what we found was that lower fetal and neonatal total brain volume, or the smaller the brain is beginning prenatally, was associated with much more significant acquired white matter injury after birth. And this is even, again, before these babies are going to the operating room. We are seeing a significant portion of them are demonstrating acquired brain injuries, mostly in the form of white matter injury. And this study suggests that potentially, if we're able to measure the brains of these fetuses before birth and sort of measure them up to what would be expected to be normal, that could be a tool to help us predict who may go on to develop significant brain injury after birth. And I think that's important because a few years ago, we showed that these acquired brain injuries that have been observed in neonates with congenital heart disease are definitely associated or directly associated with neurodevelopmental outcomes. So in a sense, these injuries sort of serve as a short-term proxy for the ultimate outcome of neurodevelopmental outcome. And what we showed was that in both transposition of the great arteries as well as hypoplastic left heart syndrome, those babies with moderate to severe white matter injury were more likely to have significantly impaired motor outcomes at 2.5 years of age. So if we can prevent significant acquired brain injury after birth in the neonatal period, that may optimize neurodevelopmental outcomes in our patients. So to conclude, I wanted to leave you with how we're thinking about this, sort of a premise of looking forward and how we're using all of this literature to think about next steps. And I'll use transposition of the great arteries as an example, where in transposition of the great arteries, we know that fetal physiology is not normal. There is decreased oxygen and nutrient delivery to the brain. After birth, these babies have a variable sort of perinatal physiology depending on the status of the atrial septum, and also the fact that they go through the transitional physiology just like any other baby, but that it might be much more challenging in the fetus with transposition of the great arteries, with sort of an unfavorable, as the pulmonary vascular resistance drops, there's an unfavorable degree of pulmonary to systemic output. And then they go on to, at some point within the first few days after birth, go on to have an arterial switch operation, which restores normal physiology. And so we would expect that, that there's really no ongoing cardiovascular issues that would affect the brain. But despite that, these babies go on to have some degree of challenges when it comes to neurodevelopmental outcome, as well as psychosocial health and quality of life. And so if I overlay some of what we know about the brain in this model, we know that the fetus with transposition has delayed brain development, and that when they are born, their brains, even though they are born at full term, their brains are about 4 to 6 weeks delayed compared to the fetus without transposition of the great arteries. And we also know that in transposition, the highest risk period for acquired brain injury is actually before they even go in for their arterial switch operation. Up to 30% of babies with transposition have acquired white matter injury that occurs before the operation. And that we showed that delayed brain development may predispose these babies to this acquired white matter injury. But there's also been literature to suggest that physiologic challenges during that transitional period, whether it's gestational age at birth, whether it's significant hypoxemia, can also contribute to the risk of brain injury. So our research program is really starting to transition into looking at this time period, both the fetal, but also that immediate transitional perinatal time period, as a time where it is possible that interventions may help optimize ultimate outcomes in terms of neurodevelopment by both optimizing brain development in utero, but also by optimizing this perinatal physiology to prevent ongoing acquired brain injury after the baby is born. So with that, I want to thank our group here. We have a wonderful multidisciplinary research group here at UCSF. And in particular, I want to thank Patrick McQuillan, who's my longtime collaborator and mentor, as well as our collaborators at Sick Kids in Toronto, Stephen Miller and Mike Seed, as well as our funding sources from the NIH. Thank you.
Thank you very, very, very much, Sharon. It's a beautiful talk, and I think it's not a simple one to grasp. We'll open the floor for discussion. We'll have 5 minutes for discussion. So any questions, then we can open the chat and see if there are any questions. I have a question for you, Shaman, if I may ask you. You said this is congenital heart disease and the flow and the brain development. So do you mean cyanotic and acyanotic, or would you illustrate it as mainly left heart and transposition?
Yeah, I mean, it's a good question. Most of the studies, to be honest, have combined various forms of congenital heart disease, but the vast majority are cyanotic congenital heart defects, and most of the literature has been focused on transposition of the great arteries and hypoplastic left heart syndrome, mainly because we know that those babies need a neonatal intervention, and that sort of the physiology is, we know the physiology well for those two forms of congenital heart disease, but mostly cyanotic.
So why can't we say in cyanotic congenital heart disease? Why congenital heart disease?
Yeah, I mean, we should be more, it's true, we should be more specific, but you know, some of those studies, it's mostly cyanotic, but it's a mixed bag. So
yeah, exactly. But it's not going to be like a VSD, solo VSD, yeah, or something
right,
like that.
Right. It won't be a VSD. Correct.
There's a question about the mode of delivery with heart disease. Have you studied that?
Yes. So that's a really good question. It's asking, according to fetal heart disease, what type of delivery should be recommended? And so we don't, the finding of congenital heart disease, even severe congenital heart disease like hypoplastic left heart syndrome, should not affect mode of delivery for the mother. So vaginal delivery is perfectly safe for the fetus. Now, the only exception to that is if there is a congenital heart defect that's going to require an absolute immediate intervention. For example, hypoplastic left heart syndrome with an intact atrial septum, where we know that there needs to be something immediately done. A lot of centers do recommend a C-section delivery, but for the most part, if it's sort of your run-of-the-mill hypoplast who's going to go on to get a Norwood, we don't recommend C-section delivery. We recommend near full-term vaginal delivery.
So the message is full-term vaginal delivery for almost everything, apart from few things, and the hydropic babies, of course, fetuses.
Yeah.
Rima?
Yes, please, Mark. Yeah.
Shaw, that was just an outstanding, brilliant talk. Thank you for summarizing so much so well. I know I'm interested, and I think others may be interested in your thoughts on terms of fetal interventions to improve neurodevelopmental outcome, particularly maternal hyperoxygenation. As you want your thoughts, because of course there may be downsides or concerns about maternal hyperoxygenation in terms of neurodevelopmental outcome. I think Abe Rothman and others have written about that. Could you share your thoughts about that?
Yeah, it's a really good question. So the paper that I mentioned that we just published actually has a component where we gave maternal hyperoxia to look at sort of the acute effects of maternal hyperoxia on cerebral tissue oxygenation in these fetuses with congenital heart disease. And interestingly, our findings were, it was very variable. So it wasn't like we saw this immediate increase in tissue oxygenation in all the fetuses with hypoplastic left heart syndrome or transposition. And I think, you know, my conversations that I've had with Dr. Rudolph over the years, we should be cautious about this. You know, it seems like a very easy intervention. You can give mothers oxygen and it's sort of non-invasive and it's not very difficult. It's sort of low risk to the mother. But there's been some parts of studies that have been concerning that it may lead to, some of the studies have shown that the fetus may be smaller at birth, the ones that received chronic maternal hyperoxia for other reasons. And it's unclear if there is a sort of sustained benefit to the brain. Like if you just give the mother oxygen and the fetus, the sort of arterial oxygen level in the fetus goes up, whether the change in the cardiovascular physiology that we see transiently is sustained over the course of, you know, several weeks or months that we're administering chronic maternal hyperoxia, that it would actually benefit the brain. Mike Seed and his group have a study right now, a trial going on where they are administering chronic maternal hyperoxia to fetuses with hypoplastic left heart syndrome. I've seen some of the preliminary results that, you know, there seems to be some improvement in brain growth in the ones that receive chronic maternal hyperoxia, but it's a very small number so far. So I think it's still not clear, and it's a very complicated intervention.
Thank you very much. We have few questions here, but I'm not sure. From Sirisha Balmuri, do you do pre-op MRI in all congenital heart disease needing repair within 1 year of life?
Yeah, right now, we are still doing our preoperative MRIs on a research protocol. So we are not performing it on every single baby. However, there are several sites in the US as well as in Toronto that any neonatal congenital heart disease, more often transposition and single ventricle type lesions, those babies are routinely getting both pre-op and post-op MRI. There's about a handful of centers across the country that are doing that on a clinical basis. And I think it's, you know, I think it's important. We know that there are these acquired brain injuries that we see. We know that they're associated with outcome. So why wouldn't we want to know if we can do these MRIs, why wouldn't we want to know if a baby has significant brain injury? Because it might influence what we recommend after the baby goes home in terms of early interventions and developmental care to optimize outcomes.
I think the surgeons would always like to have an MRI pre-op, right? So to know where they're standing rather than blaming them for the post-op complications.
Yes,
thank you very much. Thank you.
I think we're going to have to move on now. Thank you so much, Shab, for an absolutely fantastic talk.
Our next speaker is, thank you. Let me introduce our next speaker, and Dr. Mark Skalinsky. He's the Chief of Pediatric Cardiology at UCLA Hospital and Professor of Pediatrics and Pediatric Cardiology. Welcome. And thank you for accepting our invitation.
Sorry about that. I'm a little IT challenged, but I think I figured this out. Okay, now can you see and hear me? No?
Yes, I can see and I can hear
you and hear you. Thank you, Mark.
Thank you. Okay, so good morning, good afternoon, good evening to everyone. Thank you, Rima and Norm, for inviting me to join this group today of two other outstanding talks today, and I'm hoping you'll enjoy this short presentation I'm going to give you on something dear to my heart is in terms of improving prenatal detection of congenital heart disease. What are we in our guidelines doing wrong? And I'll cover some basics and then get into some guidelines and some controversial topics that I'm hoping to make you all think of what your own opinions are about some of the things that I'm going to be talking about. So again, thank you for giving me this opportunity to speak with all of you. Sorry we can't be in person, but hopefully someday we'll be back to being able to meet each other in person. So let's see. So not sure who we're talking to. There's a couple hundred people out there watching this around the world, but just a quick review for those who don't know, congenital heart disease happens, I think about 1 out of 100 babies is born with a major heart defect, and critical heart disease that requires early intervention, about 3 out of 1,000. Those are the ones most likely to benefit in terms of improving outcomes. Shab gave such a wonderful talk about neurodevelopmental outcomes, but even just in terms of survival outcomes and other kinds of aspects of outcome, prenatal detection is so key. Most common form of birth defect of any kind, of course, is congenital heart disease. It accounts for almost half of all deaths related to birth defects. And notice on the upper right, this clip, we'll come back to this view. This is my favorite view for screening. So the importance of early detection. Why is it so key to pick up heart disease early? Well, it turns out that most childhood deaths from congenital heart disease and preventable morbidity occur in the first hours and days and weeks after life. And it's usually because of a missed or delayed diagnosis. So we can improve our early detection. We make significant impact on outcome. Of course, we can detect congenital heart disease and often do, if not usually do this after birth. But as many of you probably already know, I may be preaching to the choir, prenatal detection is far superior to detecting congenital heart disease after birth. First of all, we're already doing an ultrasound in almost every pregnancy throughout most of the world, not all the world, during the second trimester, at which time the heart is visualized or should be visualized. There may be a potential impact on prenatal natural history in a very small subset, maybe with some interventions that Shab touched upon, maybe with fetal arrhythmias, of course. But the vast majority of impact of prenatal detection is not because we can alter the prenatal natural history as much as we alter the delivery and postnatal natural history. So of course, once we know about the heart defects, say we have a baby with hypoplastic left heart with a restrictive atrial septum or transposition with a restrictive atrial septum, we want to deliver those babies in a center which can manage those babies. We avoid early compromise. So most babies who are born without a diagnosis may develop problems during the first 12, 24 hours as the ductus close. If we know about the congenital heart disease, we won't let the ductus close, and we can avoid that physiologic compromise that can impact outcome, including neurodevelopmental outcome. And of course, we know about the heart defect early, prenatally. We can then initiate the appropriate management even in the delivery room. And actually, in terms as what was alluded to during Shab's talk, is where and when we deliver, how we deliver these babies, it may be impacted by the prenatal detection. If we don't know about the heart defect, we can't do that. So the problem is then, why are we still missing congenital heart disease? I think it's clear to all of us here around the world who are involved that it's so key to outcome to detect heart disease prenatally, but we also recognize that we're not so good at it. There are sections places around the world which are quite good, but still the vast majority of us are living in communities, even us here in Los Angeles, where detection rate is quite poor and not nearly good enough. So the issue is why are we still missing heart disease? And those of us who have been doing this a long time, and I've been doing this almost 30 years now, I guess, but have developed some ideas, and there's been a lot of work looking into this. And I think we all have a better idea now of what we need to do. I'm sharing you my own personal thoughts about that. So I was just scanning yesterday. This is what happens all the time. You get a fetus, the baby's not in a great position. And how do we get the baby in a reasonable position to optimize the image? I think that it's really the crux of the matter, honestly, in terms of why heart disease is missed most of the time. And that's not so easy to solve. But there are some things we can do. Just because a problem is challenging and difficult doesn't mean we can't make an effort to solve it. So how do we optimize image quality? Well, of course, optimizing the probe. I always pick the probe with the highest megahertz of highest resolution and see if I get adequate penetration, and then go from there. You want to optimize the probe position on the maternal abdomen, and where that probe position varies. It varies by time, where the optimal position at one point in time may change the next second, and then change again the following second or the following minute. And it may be different if you're looking at the crux and if you're looking at the pulmonary valve, or if we're looking at the ductus, or you're looking at AV valve regurg and so on. Probe position you want to optimize depending on what you're looking at. You want to optimize the maternal position, meaning that, if you don't have the right angle, you're not seeing what you want, then you have the mom go on her left or her right. Sometimes we have her go in other positions. We optimize the fetal position. If the baby's in a bad position, how do you get the baby to move? Well, there's various maneuvers. We all have different approaches. Have the mom go to the bathroom, have some cold water, jiggle the belly a little bit, jump around the room, but those maneuvers can be very effective and make the difference between detecting a heart defect and missing it. But they take time, and that's clearly the issue. A lot of these efforts do take some time, but my point overall is that it's worth the time. Given how important it is to improve detection, it's really worth the added time. Then optimizing transducer pressures. I've gone to multiple offices where I was able to get images that people in those offices using those machines had not been getting. And it's really related to, I just pushed harder, pushed a little harder with the probe. And so I think a lot of us can improve our imaging by optimizing transducer pressure a little bit more. Then of course, optimizing depth and sector width and zoom as well. These are all really key aspects to improving imaging and improving detection. Here's just an example of depth going from the left to the right. You can see the improved image quality just by changing the depth. Then here it's changing the sector width. We're wasting all this resolution on the left. We want to bring this, and these concepts apply to pediatric echo, of course, that we teach our fellows, but particularly for the fetus. We want to optimize resolution by minimizing the width, optimizing zoom. And here we've gone from 35 to 114 hertz. You can see the image quality is dramatically different, improved. This is another really important concept. What are we looking at right here? You can see this is a road. It looks like there's water on the road. It's a mirage. It's not really there. It's an optical illusion. It looks like water, and we've all seen this, particularly in the desert, but lots of places. And how do you figure out if it's real water or not? You need to get closer to it, or you move your angle, move your head up, look around, and ultimately figure it out. Well, the issue is fetal echo is full of possible mirages or optical illusions like this that are many of which are based upon the angle that you're looking at the heart. So you need to be able to recognize that and then to optimize the angle of acquisition in order to detect heart disease, not to overcall heart disease, which happens a lot, and not to miss heart disease. They go hand in hand, of course. Very important aspect of detecting heart disease prenatally. And here's an example of an outflow tract evaluation. This is not the way we really want to evaluate outflow tract abnormalities. I'm not saying that it's not possible to evaluate. I'm not saying that you can't look at this heart and say, oh, that looks like aortic override, and you're probably going to be right. But the problem is we're dealing with statistics, and you want to optimize your odds. And so you want to get the best quality, best angle that you're going to optimize your odds day in and day out, not to miss, not to overcall congenital heart defects. So this is not the way to do it. This is my favorite view, being relatively perpendicular. You don't have to be exactly perpendicular, but relatively perpendicular to the ventricular septum to evaluate to see if dropout is real. And I left the left ventricle on the bottom, right ventricle on top. For multiple reasons, I think it's preferable. And you can see this Irv Tesler drawing he gave me, and some of these drawings come from my chapter in Increasing Resnick, these diagrams that are in this talk. I have no other disclosures. This is the view, my favorite view. You can see the LV on the bottom, RV on top. You can see the left ventricular outflow tract. You can see the aortic valve opening and closing, disappearing during systole. It's nice and thin and delicate. Same thing for the pulmonary valve. You can see the ascending aorta, the size of the ascending aorta, the angle it's coming off the LV, the septum, the RV and LV function, so on and so forth. Very powerful view. But you need to be relatively perpendicular to the ventricular septum to rule out defects, ventricular septal defects in a reliable way, consistent way. And this is what I call my favorite view 2.0, because it takes just a little bit of angulation from this left ventricular outflow tract to this, the left ventricular inflow tract, to look at the crux. Really important to see the crux, of course, in every single fetus. And I really like this view. This is not the view to look for AV valve or Gurge, of course, but it is a very good view to look to rule out AV canal defects, because you can see the lower part of the atrial septum is intact. The mitral and tricuspid valves come together. Sometimes you'll see the offset here, but really importantly, this is an important view to show that the inlet septum, just underneath the mitral and tricuspid valves, is intact. This part of the septum is almost invariably, if you look at this part of the septum parallel to the septum, you'll see dropout. It's very difficult to tell if that's real or not without optimizing the image and optimizing the angle. So I really love this view. So my point of this slide is that when we do fetal cardiac screening, we look at different views. We do abdominal situs, four-chamber view, RVOT, three-vessel view, hopefully. And when we're doing fetal echo, we're looking at structures. And we can think of, but in neither case should we be thinking about fetal cardiac screening for views or fetal echo for structures in terms of a checklist. A checklist means you see it, it's there, you're good to go. That's not the case. It makes all the difference in the world if you're seeing the mitral valve well, or you're just seeing the mitral valve and can check it off on your checklist. So my point is, optimizing the image and the angle are so key. It can make all the difference between detecting a heart defect and missing a heart defect, or overcalling a heart defect, frankly. So color Doppler, also really key. The color Doppler also takes some learning to optimize, but can be really powerful, even in low-risk pregnancies. And so you might be thinking, well, these are great ideas, but how do you do it? It's hard to get all that, transducer pressure and all these different, the angle and this and that, and it is really hard for me. And I do all my scanning. It's very hard to do this with one hand. I can't get the pressure, hold it tight, use one hand and then push the button to acquire it. I just can't do it. I can't hold my hand still where I need it. So I almost always will be using two hands. I'm a big advocate of two-handed scanning. It seems obvious to me when I'm scanning. More and more people that start to do this seem to find, yeah, it does help a lot. So any of you who haven't tried it, I encourage you to try it. We published this paper about the foot pedal because if you're doing two-handed scanning, it's sometimes hard to acquire the clip, pushing unless you have three hands or you have an assistant. So a foot pedal can be really useful because I started doing this. I would have the picture and be ready and say, okay, acquire. And I'd start barking, yelling because they wouldn't do it fast enough. It really helps. It's very inexpensive. It's a really great addition to your scanning capability. So let's talk about the guidelines. Given that background about image optimization and angle of acquisition, what do the guidelines say about some of these considerations? These components on the left, these are what I believe are really key, both for screening and we're going to talk about fetal echo guidelines too briefly. Really key for every single fetal cardiac screening examination. Clips, color flow, four-chamber and outflows, three-vessel, and then considerations of angle of acquisitions that we've talked about, and scanning techniques to optimize image quality, the same ones I talked about. Let's see what the guidelines say. These are North American guidelines and from Europe, ISWAG and AIUM. Of course, there's other very good guidelines out there as well. No disrespect, I just am showing you a couple of them. ISWAG from 2013, and AIUM from 2018. Clips were required by ISWAG, not required in our guidelines in AIUM. Core flow not required in either set of guidelines. Four-chamber and outflow in both. Three-vessel view not required in either. Angle of acquisition not mentioned at all in AIUM guidelines, mentioned briefly in ISWAG. And then the scanning techniques not mentioned either. So I think this is a problem. I think that the guidelines are always state and that they're not meant as a legal document in the court of law, but of course, guidelines are very powerful and they do impact what we do as a community. So I think it would be useful for, and as you know, we keep revising our guidelines, and it's not easy to go from this to add all these considerations in our next iteration because it takes a lot of training. There's a lot of resistance, and I get that. But honestly, I think ultimately we would be doing future children with congenital heart disease a favor by bringing these considerations into guidelines for even low-risk pregnancies in the future. So let's talk about fetal echo guidelines. These are high-risk pregnancies. What are guidelines? Again, just two sets of same two organizations, AIUM and ISWAG. AIUM actually just revised their guidelines last year. ISWAG is probably they're probably coming out soon because it's been a while. These are, again, similar components of my choosing that I feel are really key take-home points of what to include. And these pretty much are included in all sets of fetal echo guidelines, except these scanning techniques were not discussed in ISWAG guidelines, but they are discussed in AIUM as an angle of acquisition. These were revised, this is new as of 2020. I was very pleased to see. So what were the changes? It's actually interesting to see what were the changes in the AIUM guidelines for fetal echo between 2013 and 2020. Again, these are the components that I your take-home points of things to try to always think about and include when you're scanning even low-risk pregnancies as well as high. The difference you could see is angle of acquisition scanning techniques were added in 2020. And what was added are the mandatory cardiac biometry, all four valves, measuring all four valves, and mandatory pulse oximetry of ductus venosus for all four valves, and one vein on the left and one vein on the right. This is where it gets a little controversial. Well, it's already gotten a little controversial, I think. But the issue is, what is the benefit by including these quantitative measurements as a routine in fetal echo? And this is a whole discussion of itself. We could have a whole day a webinar on this conference, and hopefully we will. I'll just leave you with one consideration or two. One is, what is the benefit from including these in otherwise normal fetal echoes? And is there any harm in including requiring such quantitative measurements? And I can tell you, I believe that there is potential real harm in terms of prenatal detection for congenital heart disease. I don't want to run on too much time, otherwise I'd have cases going into that. We'll do that for another time. But at the same time, let's say you have a fetal echo that looks abnormal to the eye. In those cases, I think it really is important to do quantitative measurements. What I was reviewing was mandatory for every single fetal echo. But of course, whenever we're seeing something abnormal in a heart, quantitative measurements can be very useful. And we learned that in the hard way on this case. This is a case we were not doing that. This is a case of small right heart over here. We saw at 21 weeks, this is a few years ago. We were following this baby with time. Not sure what was causing it, but noting here that the right ventricle still looked maybe a little small to us. Some of you may be thinking some other things, hopefully. But we were thinking that the right heart was small, when in fact, the left heart was big. And this was a case of Marfan that Sunitra Naween and our colleagues wrote up, during which we did not do Z-scores. We just looked at the time, we did not do, we just thinking the right ventricle was smaller, the left was big, and the left was big. We thought it was compensate because of our primary problem on the right. But that wasn't the case. If you look at the Z-scores down here, the bottom, you could see these are all above 2. These are all the left-sided structures, starting with the aortic root early on, and the mitral valve and aortic valve, all significantly abnormal and dilated throughout the pregnancy, but even early on, before 22 weeks, the aortic root was dilated, whereas the right-sided structures are all normal. So the message here is that's one part of the heart is big or one is small, you're not sure which. The answer is to do quantitative measurements and get Z-scores and to follow with time. Now, of course, if you do when you do quantitative measurements, it's always important to make sure that you do them in a reliable, reproducible way, which requires optimal imaging and optimal angle of acquisition. A few other things, I try to go through this a little quickly, but it's not good enough. Once we detect a heart defect, that doesn't mean that the baby's going to do better, right? I mean, it's important to, what do we need to do after the diagnosis? Let's say we diagnose at 30 weeks or 20 weeks a fetus with Ebstein's anomaly, severe Ebstein's, say. That's not going to make that baby do better. It's a matter of what we do with that information, of course. So we want these babies with high risk critical forms of congenital heart disease to be managed and delivered by a team with experience with these types of diseases, and delivery at a tertiary care center of excellence so that everything can be optimized, starting in the delivery room or before that, and then early postnatal course. The problem is sometimes the detection of heart disease does not lead to improved outcomes because there may be obstacles. There may be obstacles that are insurance related or contractual or financial or even political or other types of obstacles, which we also want to address, because if we've done the job of making a prenatal diagnosis of a major heart defect, we don't want anything to get in the way of allowing that to optimize the outcome for that fetus. Then finally, before I sum up, just talking about counseling, how should counseling, this is such a huge aspect of what we do and what so many of us love to do once the diagnosis is made. Of course, when we counsel, we need to do it with compassion. I say, of course, but it's so key and something we all have the power to do. No matter how bad the diagnosis is, we can give a gift that keeps on giving, that people will not forget if we do the diagnosis and counseling in a compassionate way. This is a little editorial I wrote a few years ago. I'll just read briefly an excerpt that the fact is how we give bad news may be remembered as much as the bad news itself, which is true. Most of us know us that firsthand. I certainly do. We can practice compassion-based medicine, or we can simply dispense data to the most vulnerable in our care, but our patients will remember either way. I believe you'll feel that's true. And so it's something we can always do, no matter how bad the diagnosis, we can still give something of great value to the family. We also need to do counseling with expertise. This is a internet survey of 841 parents of children with congenital heart disease who told us what was lacking from the pediatric cardiologists in terms of the counseling in their experience. So this was useful. Most just in terms of percentage, highest percentage felt that they were missing more. They wanted more information. They wanted more information in general, as well as long-term issues, quality of life, maybe neurodevelopmental outcome, more survival rates. And again, when we give some survival rates or any information regarding information about what the outcome is, we need to make sure to tailor it to what's relevant for that patient. If that patient is in a small remote community that's going to have that can only get certain type of care, you don't want to be quoting what the outcomes are at a major academic center in a developed country. You need to give relevant data. And then written information diagrams, many patients said that they wanted more of that. They wanted to know about survivor or support groups, and they wanted, in many cases, more compassion and more reassurance. I thought this was a really useful study. So to sum up, covered a lot of ground, some pretty basic, some hopefully will be useful to you in your own practices, and some controversial for us to all consider as a community in terms of our guidelines. But improved prenatal detection of congenital heart disease can be achieved with improved image quality and appropriate angles of acquisition, the acquisition of clips rather than still frame images. Many people are still just doing still frame images, the use of color, even in low risk pregnancies, and the inclusion of the 4-chamber view, the LVOT, RVOT, and 3-vessel views. And again, consider the foot pedal and 2-handed scanning. Current guidelines fall short in important areas and should continually be reconsidered and revised over time as we as a community get better, technology improves, so on and so forth. Translation of early detection of congenital heart disease into optimal outcomes requires a collaboration between maternal fetal medicine and pediatric cardiology, and sometimes overcoming other obstacles that should not be obstacles, but in some settings may be. And then counseling following the prenatal diagnosis of congenital heart disease should be performed with compassion and by those with relevant expertise. So I think I'll finish up there. When we're done with this pandemic, we've had many visitors from around the world come to visit us. Such a pleasure having people come to visit us. We look forward to being able to have you visit us again. Thank you again for your attention.
Thank you, Mark. Beautiful talk as usual. And we have a few minutes for questions. And this is a beautiful talk compared to the one before. As you said, on our webinars, we're going to have one basic talk and one advanced talk. So the one before was advanced, and this is very beautiful basic. I just want to ask you before we get any questions. Now, there's one talking about guidelines. We were just discussing this with the IVF patients. Now, the American Society in 2014 said they should have fetal echo. The obstetricians, the one I talked to, the MFMs, they're saying there are no guidelines for screening, doing fetal echoes and as routine on IVF patients. What do you think?
Well, thank you, Rima. First, I disagree. It's the talk is basic in some ways, but in other ways, the concepts are intuitive, but important and somewhat more nuanced than people might think at first. So I think I hear what you're saying, but it's the concepts are pretty deep. And this is a very important question you raised about IVF. I think in general, the reason to do a fetal echo is to improve the ability to detect a heart defect that was missed by the anatomic screen, right? So I think, and I talked about this in our chapter, it's really, the indications vary depending upon the community. What's the added benefit from a screen, whoever's doing the screen, compared to who's going to be doing the fetal echo? In some communities, the person doing the screen is way better at evaluating the heart than the person doing the fetal echo, in which case fetal echo doesn't add a whole lot. If you're in a community where the people doing fetal echoes can evaluate the heart better than those doing the screen, which is the case in many places, including Los Angeles, then there are indications based upon the increased risk for heart disease over the baseline risk. And IVF, my reading of the literature is that I'm convinced that IVF pregnancies in general have a higher risk for congenital heart disease and other malformations than normal pregnancies. And there's certain elements of IVF that may be more responsible for that. We're still learning about that. Some papers have said if it's a singleton pregnancy, the risk is not as high as the twins or above. I think we're still learning to dig down deep in terms of what aspects of IVF put the fetus at risk for congenital heart disease. In the meantime, though, statistically, empirically, I think my reading of the data is that the risk is higher in fetuses conceived by IVF in general than those conceived naturally. So it makes sense to offer a fetal echo if a fetal echo is going to be able to evaluate the heart better than the screener. Do you buy
Thank
that?
you. I'm sorry. I didn't mean when I said basic. What I was meant to say, basics is very important, of course, for us as practicing fetal cardiologists. But the one before talked about advanced information. So pardon me. Yes, of course, I quite agree. But then who makes the guidelines? Because this should be in the guidelines that IVFs or artificial babies should have echoes, because they don't want to order fetal echoes as routine for IVFs, as we as cardiologists agree that it is. Thank you very much. Dr. Silverman, do you have any question? Anybody?
Well, I do think that this is a very interesting issue. I think that the hardest thing that one can do in terms of counseling is to go and tell a mother who's struggled with the financial burden of in vitro fertilization that she's carrying a very defective fetus. It's a real problem, and certainly my own experience is that this is one of the hardest groups of people to talk to. Mark, I would just like to say that I thought your talk was the talk that one would have to have if one was going to study a fetal echo and had never done it before. It was absolutely fabulous, and your images are, as usual, always perfect. What I'm most interested in your talk is work that we've both been associated in, is has the messianic or the proselytization that we've done in terms of getting good quality images improved the percentage of referrals in the community? I haven't really looked at my data for 15 years now, and I think it might be important for us to look and see what the situation is in our own communities so that we can compare one to the other. Have you noticed an improvement in the patterns of referral? Are people just more suspicious of heart disease and sending patients to you for rule out heart disease? And do you have any idea what the positivity rate is in these patients?
Thank you, Norm. Great questions. We are looking at those questions now over time to see if the percentage of the indications for the fetal echo have changed over time, and if that can demonstrate that in fact people are getting better at detecting heart defects than they have in the past. Anecdotally, of course, I think we've all spoken with people who recognize that their scanning has gotten better because of some of us have given them some tips and they've gotten better. They've gone to symposia, but I think those are great points. And Rima, I certainly
I think Norm said it better than me. It's a beautiful teaching session.
No, I just was trying to play a little bit and to point out, but I know what you mean. Shab's talk was at quite a detailed level in a good sense, although she went from very basic all the way to very esoteric concepts. And my talk was a little more clinical, but also raises some points that Norm brings up and that you bring up.
We need both levels. We need both levels. We need one to work with, which is yours, and one to think about, which is Shabnam. And also for compassion, I think there was a paper, Dr. Silverman, if you correct me, about how if the mother is stressed, this will affect the growth of the fetus and the placental flows. So yes, if you break the bad news, we have to make it very, very in a very soft way, I think.
Sure. Actually, Rima, that's a great idea in terms of clearly the stress is not good for most things, but to certain types of stress, but that would be interesting for Shab and her colleagues or others who can image, not just looking at the maternal brain, but also impact on the fetus. And there's a lot of data showing the impact of stress on fetal development. So that's another reason to do our best to counsel in a compassionate way, because clearly we're going to be adding stress to a pregnancy. For instance, as Norm pointed out, there already is stressed in an increased stress level in an IVF pregnancy. And now if you tell them about a heart defect, it's going to be very hard for any pregnant woman to hear that.
Thank you, Mark. Thank you. Thank you
Rima,
so much.
Can you hear me, Rima?
Yes, I do.
What is your take on the referral of heart defects from your referral sources? Is it an increased recognition, or is it remaining at the same level?
No, it's an increased after working 10 to 12 years on the program. And I think the awareness is very important, and we address two lines, the colleagues and the patients themselves. So we have self-referrals as well, and we have referrals from colleagues. I think it's increasing. Specifically, I think also because we are having a lot of IVFs now in our country, and artificial insemination, I just want them to come for fetal echo. But as Mark said, the obstetricians or the infertility specialists are very worried to refer a mother with IVF pregnancy for fetal echo as routine. I'm suggesting to our colleagues here that we start doing it routine at 14 weeks of gestation, but it didn't come. And the discussion was, where are the guidelines? How are you talking? What are you saying? So I said, but as cardiologists, we know it's true, but they said, no, we don't have any guidelines from our side to say that.
Let me just make one more point, and that's that Dr. Anita Moon-Grady and I wrote an editorial on work published from the Great Center in Paris, where they had looked at all of their own diagnoses and compared the findings to the findings post-operatively. And the thing that shocked me was that even in a great center like Paris, that there were errors that were made of a really fundamental level. And it requires, I think, a great deal of concern and care when you do an ultrasound, when you find something, to look and see whether there are other things that could possibly be. And it is remarkable that in some of these patients, there was even a totally wrong diagnosis made at even the best of medical centers. So we have to be very careful about how we interpret these studies. And I think that one of the things that's very important is when you find a patient with a fetal structural abnormality, that you continue to follow them throughout the
I
pregnancy.
think always we have to be not overconfident. I think it's not a bad idea to ask the patient to come back once or twice or 3 times until you really get the correct diagnosis, even at a senior level. I think, I'm not sure if you'd agree to that.
Yeah, I think we should move on, Rima. We're running out of time. Eh?
Thank you. Our next speaker
Mark.
is, thanks, Mark. And please stay, because at the end we might have more questions if you have time. Our next speaker is a dear colleague of mine, Dr. Sausan Awad. She's a professor of pediatrics and OB and gynecology at Rush Hospital. She's a director of pediatric cardiology fellowship program. She's going to talk to us about something that we all face in our practice at different levels.
Good morning, good afternoon, good evening, everyone. Thank you, Rima. Thank you, Sasha, for the invitation to Congenital Heart Academy. And I think now the audience are about 200. So thank you for the participants, and thanks for staying that long to hear the last talk of this fetal cardiology series. My talk is going to be a little bit sort of a more continuation of what Mark had touched on. And I'm just going to go over the guidelines for routine second trimester obstetric ultrasound. In evaluation of the fetal anatomy, we are interested, of course, into the cardiac anatomy, and it has, as Mark detailed, the cardiac 4-chamber views, the cardiac outflow tracts, and the cardiac situs. But unfortunately, there are no recommendations or guidelines to do clips. So majority of times, these views are obtained as still images. On the other hand, if there is a lesion like common AV canal that can be detected in a 4-chamber view, you can definitely miss an outflow lesion like transposition of the great arteries if the initial screen for the outflows are not met. There are multiple studies out there. I'm just quoting few of them regarding the sensitivity of fetal echocardiography and the detection rate, and it varied significantly between publications and centers. This one, the sensitivity was about 88%. This article in particular was actually pointing to majority of fetal congenital heart disease were presented in pregnancies without risk factors, which means that we depend significantly on the routine 20 weeks screen that is performed by our OB and MFMs for early or identification of potential fetal congenital heart disease. This publication was pointing to the very important fact that we all deal with and face in our practices, which is the experience of the sonographers that we have in our centers, and definitely experience makes a lot of difference in improving the detection rate of fetal congenital heart disease. This study was done by Lisa in 2006. And it was interesting because it tracked the prenatal ultrasounds for those patients, postnatal patients with congenital heart disease, and figured out how many of those patients or newborns were diagnosed prenatally. The detection rate in this study was about 36%. And I would like to point in this graph from this study is that one of the most difficult congenital heart disease to detect was total anomalous pulmonary venous return that had a 0 prenatal detection in this study. I would like to keep in mind that low-risk pregnancies or no-risk pregnancies are loaded with possible fetal congenital heart diseases. Especially, we know that the congenital heart disease is about 1%. The incidence is about 1%. Cardiac evaluation during routine ultrasound is still a still image, not clips, and that probably may affect the accuracy of suspecting congenital heart disease. The experience of the performing physician or sonographer of the study in fetal cardiology is extremely important. Obviously, more complicated cardiac lesions are easy to detect versus less complicated congenital heart disease. They will have a lower detection rate. There are a certain number of cardiac lesions that are difficult to detect in fetal life due to variable reasons. For example, total anomalous pulmonary venous return and coarctation of the aorta. And definitely we have room to improve. And that's what we're going to talk about at the rest of this presentation. So parts of what we need to do to improve the detection rate is having pediatric cardiac specialists specialized in fetal imaging and cardiac ultrasound. Keep educating and training sonographers and let them have the experienced sonographers in our centers, and then continuous training as we are doing right now, the lectures, conferences, webinars, workshops, and hands-on sessions when COVID is over, obviously. Then if you are unable to get a clear image when you are doing your fetal echo, you definitely need to make a change. You can either change the transducer, the machine, the setting you are using. You can change the fetal position, and these are things that Mark touched base on in his talk. Or you can call for help, which is changing the operator. Of course, we have a fellowship training program, so our senior fellows do scan fetal patients. So we instruct them to scan for about 30 minutes only, and then if they are unable to get everything, they need to call for help, or help will come to them anyway after 30 minutes. And then, or you change the time. So translated into get the patient back for follow-up, but sometimes patients are eager to know and they do not like the fact that they don't know what's going on fully in the first visit, particularly if there is an intention to terminate pregnancy and the decision of the patient is depending on the complexity and the full diagnosis of the congenital heart disease. Or change your counseling. Basically, if you do not see the structure, do not say it's normal or it's abnormal. You just say it cannot say what's going on. Here is a proposal that requires some money, but which is called Mini Fetal Echocardiography Screen. I'm thinking that is a collaborative effort between OB, MFM, Peds cardiology, radiologist, because some of the centers, community hospitals, the screening of the pregnant women at 20 weeks gestation happens by radiologists and our sonographers. This mini echocardiography evaluation of all pregnant women should include the following. Number one, clips. So 2D in color, and includes the 4-chamber view, the outflow, the pulmonary veins, at least 2 of them, and then the aortic and ductal arches. Then evaluation by Doppler of the ductus venosus and umbilical arterial and umbilical venous vessels. Despite all of these, we can always face some difficulties that might be related to either maternal, like maternal hepatitis. It's obviously a nightmare for a fetal cardiologist when scanning high body mass index patients and gets frustrated not seeing all what needs to be seen. Obstacles can be related to the fetus, including the fetal position, the number of fetuses, the early gestation or late gestation. And of course, oligohydramnios sometimes creates poor imaging, as the amniotic fluid is an important contrast media for the ultrasound radiation, ultrasound beams. Or difficulties can be a result of mechanical or technical issues, including the machine, a transducer, or the operator, i.e. if a trainee is scanning, or if a junior sonographer is scanning the patient. And sometimes it's the nature of the congenital heart disease itself, whether it's one of those lesions that are hard to detect, or one of those progressive lesions like pulmonary valve stenosis, for example, that increases in severity later in gestation or actually postnatal, in the postnatal period, or one of those lesions that are normally present in fetal life, like patent foraminovalie, ASD, and PDA. Here are some examples of late gestation scan. You can definitely see the heart, but you cannot really see detailed structures of the heart in late gestation. This is another example of having a shadow over the cardiac location that preclude appropriate evaluation of the cardiac structures. I'm going to talk about 2 of those lesions that I mentioned earlier that are hard to detect: the total anomalous pulmonary venous return and the coarctation of the aorta. Here is one of the patients that was transferred to our center from an outside hospital due to persistent tachypnea. In our center, at about 11 days of age, a murmur was heard, and then an echo was ordered, and non-obstructed total anomalous pulmonary venous return was diagnosed. In tracking and reviewing the prenatal ultrasound at 20 weeks gestation, obviously we had, there were no clips, there were only still images. And you can see here that at 20 weeks, you can see right-sided dominance. You can see that the wall of the left atrium is smooth. You can see this gap between the aorta and the posterior wall of the left atrium. Of course, that was not detected. Here is another image showing that there is a gap between the aorta and the posterior wall of the left atrium. And not seeing, obviously there were no clips. This is a second case relatively recently, maybe last month or so. That was an 18 hours old male newborn was found to have tachypnea during the morning evaluation in the mother baby unit. This mom was actually with no risk factors, due only advanced maternal age. The newborn, once transferred to NICU, saturation was found to be in the mid-70s, and then an echo was called and showed obstructed supracardiac total anomalous pulmonary venous return. In tracking and reviewing the prenatal ultrasounds for this patient, there were also no clips of the cardiac evaluation during the routine ultrasound. There were a November scan, a December scan, and a January scan, and there were no clips. But in this initial scan for this mother, you can see that this is a left atrium. You can see it's relatively small, and you can see this space between the posterior wall of the left atrium and the abdominal aorta. In some publications actually pointed to interesting areas of or some clues of identification of total anomalous pulmonary venous return. One of them is the RV dominance, particularly before the 28 weeks gestation, small and smooth wall, small left atrium and smooth wall, posterior wall of it. Dilated coronary sinus if there is any pulmonary veins draining into that, and then the abnormal vessel draining into IVC if it's infracardiac, and recommended evaluation of pulmonary veins, all of them. Another study actually pointed to the increased retrocardiac distance, which we kind of seen in the still images of the prenatal ultrasounds in the previous two cases. In this same study, there is an algorithm in evaluation of the four-chamber view in routine ultrasound, and step-by-step guiding the operator to whether put the patient into the category of suspecting total anomalous pulmonary venous return and referring to fetal cardiology, or not suspecting that, and then moving on with the routine follow-up. Incoarctation of the aorta, which is a left-sided lesion and highly associated with other cardiac lesions like VSD, mitral valve abnormalities, and aortic valve abnormalities, and it's occasionally progressive towards the end of pregnancy. Certain clues to fetal diagnosis also is right ventricular dominance, showing a bidirectional or left to right shunt across patent foraminal valley, which is opposite of normal. Hypoplasia of the transverse aortic arch and retrograde flow in the aortic arch. So whether to see all of those or some of those, and you should say coarctation of the aorta is highly suspicious, and then postnatal evaluation is absolutely indicated. This next case was a gravida 5, para 4. She was advanced maternal age and referred to our fetal cardiology clinic for suspecting abnormal four-chamber view during the routine ultrasound, and looking into the earlier the earlier evaluation, you can see that the left side, the left ventricle is kind of small, the left atrium is kind of small as well, and you can see a dilated coronary sinus here. This is a little later scan follow-up in our echo lab, and you can still see that the left side is small. The outflows showed that very clearly the transverse arch is kind of small. In this clip, I would like to point to the complete left to right direction of flow across patent foraminal valley, which is indicative of left-sided obstructive lesion. This is a power Doppler, color Doppler, where it doesn't show the direction of flow, but it delineates the lumen of the vessel, and you can definitely see the hypoplasia of the transverse arch. Again, another view of the same hypoplasia of the transverse arch. This patient was operated on after delivery because the diagnosis was confirmed. Despite that, also sometimes we do not get appropriate detection rate, and then we get to face babies with congenital heart disease that coming to us out of surprise. So here is another proposal, which is a mini postnatal echocardiography screen, and also that would require some money if we need to implement it, which is going to be a collaborative effort of pediatricians, pediatric cardiology physicians, and sonographers. And it's a form of a mini postnatal echocardiography screen of all newborns that I propose to include the following: clips with 2D and color comparison of a 4-chamber view, outflow, pulmonary veins, aortic arch, and then Doppler evaluation of aortic arch, abdominal aorta, and pulmonary veins. By doing that, probably we can rule out the major and critical congenital heart disease that can affect the mortality and morbidity of the newborn. Of course, we cannot detect progressive congenital heart disease. Let's review some facts together. One of them is the more complex congenital heart disease, the higher the detection rate. And detection rate depends on operators' experience. We cannot deny that. There are alternative ways to have higher detection rate, including postnatal pulse oximetry screen, which is not 100% detection rate either. The two proposals I presented to you today. And then the last, which is the fetal cardiac MRI, if it has an impact or a role in detection of fetal congenital heart disease. So fetal MRI at this point are very well known and used in fetal congenital diaphragmatic hernia and fetal brain anomalies. And fetal cardiac MRIs is an emerging field. It's not used as a routine or the only way to evaluate fetal cardiac anomalies. It's in adjunction with fetal echocardiography. It has its own limitations due to motion artifact and fetal heart rate, but there are works to improve and overcome those limitations. In these publications, with 2D fetal cardiac MRI were obtained in certain number of patients. And of course, the 2D images were unclear. The motion corrected 3D images were much better, as I'm gonna elaborate on in the few slides coming up. This is one of our patients who had fetal congenital diaphragmatic hernia. The patient received a fetal MRI, and she was sent for us for evaluation. But let's review her fetal echo, and you can see the heart is pushed to the right side of the chest due to the significant diaphragmatic hernia. Intracardiacally, there was a large VSD that is probably with an overriding aorta, and it seems like the clip is not moving well. And this patient also had the 3-vessel view showed bilateral SVCs. And interestingly, which I'm gonna move on to the next clip, is that this persistent left superior vena cava drained into what looked like unroofed coronary sinus. So this patient received a fetal MRI, not a cardiac MRI, but looking into these images, although not focused to the heart, but you can see the cardiac shadow, you can see the 4-chamber view, you can see the atria, the ventricles, and you can see the VSD. But of course, the images are not as clear as we expect. This is sort of a 3-vessel view, but again, it's not as clear. Again, this is a 4-chamber view. You can see the ventricles, you can see the VSD, and this is the level of the atria. And these are images from that article I quoted, where a 3D reconstruction of the 2D MRI, fetal MRI, were performed. In this case, actually showed that a vascular ring and diverticulum of Kummerow. This is the postnatal, and this is the surgical view. Again, quoted from the same article, this is a prenatal MRI with the 3D reconstruction software used to show that there is anomalous drainage of the right pulmonary vein into the IVC, and that, of course, was confirmed in the postnatal by CT angio and 3D reconstruction. This one in the fetal MRI was showing the MAPCAs, pulmonary arterial MAPCAs that were detected by the same technique of the 3D reconstruction, and anomalous left subclavian, apparent left subclavian artery. And that was actually confirmed in the postnatal period. And these are the images, the 2D fetal MRI images that reconstruction, 3D reconstruction were obtained from. And this is the last I coded from this article where it shows the coarctation of the aorta, and you can see the hypoplasia of the transverse arch after the 3D reconstruction of the 2D MRI images. And in summary, the fetal echocardiography and cardiac evaluation has its own limitations, as we discussed. Many fetal and postnatal echocardiography screen may be a way to overcome that these limitations, but it requires significant budget. Fetal cardiac MRI is an emerging field that we definitely will see how it helps in improving the detection rate of fetal congenital heart diseases. Adding the 3D reconstruction of the fetal cardiac MRI produces extremely promising images, and particularly for those lesions that are difficult to detect in fetal echocardiography and other means. And by this is the end of my talk. Thank you very much for listening.
Thank you very much for a beautiful talk, Samson. Now the floor is open for discussion, and we have one question from Joanne saying, do you use special presets for fetal echo, or just using preset on machine Volizone? What then she is asking, or he's asking about chroma, brown, not black and white. So because some would use the chroma, so she's asking about the presets and the Volizone. So I would gather this is an MFM specialist rather than a pediatric cardiologist.
We definitely do have our own setting, fetal cardiology setting, and it's implemented in all machines that we have in our center. Of course, these settings are very variable in other centers that I go to, where there's community hospitals, and it's not as good as we use at our main center at Rush.
So the presets simply means that use whatever best for the machine, and ask the help for the from the application specialist, and try to adjust the images to be crispy. Dr. Silverman, can you add a little bit, because you're the master of these things? Would you advise the attendees about the fetal echo presets? Oh, he's not there. Is Mark there? Is Mark there? Oh, no.
Yes, Reem, I'm here.
We talk about the presets, the question about the machine presets for fetal echo.
First, Safan, what beautiful talk. And as always, and so nice to see you. And yeah, absolutely. I think the presets are so key. I'm sure Norm will agree that you need to optimize the settings for your own liking. That I like sepia, other people like just grayscale. That's fine. But in terms of optimizing the color and optimizing the 2D imaging is so key. And we all have our own preferences, how soft to make it, how contrasty, and you can work with the representative for your vendor to help you get to make it just right for you. Norm?
Hi, thank you, Susan. I would like you to, if you can, put up the reference on the Q&A or on the chat for the MRI study. I missed that.
Sure.
But I think that, thank you. What I think is important about total veins is it's still an underdiagnosed issue. And if you look at the Gunnison paper and the paper from 2007 with Dr. Hornberger, we we found that veins had certainly improved in their ability to be diagnosed. But in all honesty, the veins that are important to miss are the ones that are obstructed. Other total veins is not so serious because this is the last critical remaining issue in fetal diagnosis. And in fact, Dr. Jacobs, one of the Jacobs boys, has published a paper where he's taken patients with fetal echo directly from the delivery room into the operating room to repair their obstructed pulmonary veins. The issue with many of the patients with total anomalous pulmonary venous return with obstruction is they have other congenital heart disease. And so I think that it's very, very important when you see a fetus that has got perhaps bilateral superior vena cava and other issues to consider whether the veins are abnormal. And I think that's something to focus on. Of course, in the series that we published with Dr. Gunnarsson, this was quite frequent. So, you know, the fact that they had, in many cases, right isomerism, they were also considered to have this as a high possibility. So I think that we still aren't perfect in terms of looking at total anomalous pulmonary venous return. From my point of view, I just want to ask the group here, is the inclusion of a 5-chamber view to show the outflow tracts of the great vessels from the ventricles now standard? And is that, not including that, does that, of course, excludes a lot of patients with congenital heart disease, but is that considered now absolutely mandatory to do as part of our echo? And Mark, maybe you're up with the guidelines, whether this is included in the AIUM guidelines now.
Sure. Norm, you mean just the left ventricular outflow tract, the aortic valve, ascending aorta, and then the RVOT? Those are both required.
Yes.
But they are required. But but again, does not say it needs to be a good view, and it doesn't just that you need to visualize it, and it depends upon the angle and the quality whether you pick up some abnormality. But those are required. Whereas the 3-vessel view is at least in AIUM, it's still, if technically possible, then a 3-vessel. So a 3-vessel view is not required at this point in low-risk pregnancies in AIUM guidelines. But the outflow tracts, LVOT and RVOT are, which I think is really a great stride forward. Those were not required just maybe 10 years ago.
I'm just thinking of transposition because in the 3-vessel view, transposition has got the I formation. You see one great vessel, then you see the other. You don't see the 2 great vessels side by side. So it's a very important view. Of course, you showed on your second picture today already the fact that you can recognize transposition very, very easily if you get a left ventricular outflow tract view from your parasternal long axis equivalent in the fetus. But I think that that's one of the issues that I think is very important. And the 3-vessel view is really so phenomenally valuable in terms of looking at arch anomalies, for example, an anomalous subclavian or a double arch or something of that description in the vascular ring possibility. That and we see that better in fetal life because there's no lung tissue obfuscating the ultrasound tissue.
Yeah.
There is an important, thank you. Martha. Now I'm saying this is very important, but let's focus on one basic point that Sausen said. That in the case that was missed, there was RV and LV asymmetry. So the question goes for the group here, when would you think this RV, because this is, I mean, even in the case that was also shown, there's one said, this is a small LV, this is a big RV. So what would you tell the audience, about from your vast experience as a group, when is the RV okay, just by eyeballing it, and at what gestation you would say this is normal or dominant or not dominant?
Yeah, well, I mean, I think that first, image quality is key, but then if you have a good image and you believe that it's not right, then I think it's appropriate to measure and to do quantitative measurements and Z-scores. You could do it of all 4 valves. I like to do all 4 valves, but that's not so easy to do reproducibly sometimes. Sometimes babies are tough, but then you could also do the ascending aorta and the PA. There's Z-scores for all these structures, and you can see which is normal. Maybe both sides are normal, but maybe there will be some pathology. And then, as Norm mentioned earlier, it's important to follow over time to see if there's progression. And then the TAPVR is quite a tough diagnosis to make, as people pointed out, but I think we're getting better. Norm and his group and others, we also have published some clues. I think we're all getting better at finding ways to look more closely at the left atrium and the descending between the descending aorta and the left atrium, looking for the so-called twig sign or sausage sign behind it. So this is all good. This is a great discussion, and I agree with Norm that the 3-vessel view is so key. But for transposition, just let me throw this out, that it's a very tough diagnosis to make, to detect sometimes prenatally. And I think the key for transposition is to do a sweep, not just clips, but actually to do a sweep from the 4-chamber across the LVOT, RVOT to the 3-vessel view, a slow sweep. And that's the way to pick it up. Our MFMs at UCLA have picked up transposition just by doing the sweep. They didn't know what was wrong, but that they sent us the sweep, and it was clear from our perspective, and we evaluated it was transposition.
Dr.
Well,
Silverman, what about what's your view about the RV and LV? Yeah.
Hang on a minute. I think that the issue about chamber size, when you look at it relatively, it could be a big right ventricle, or it could be a small left ventricle, or vice versa. And the only way you really can get to do that is to look at the normal standards and see where the ventricle and the annulus of the AV valve are in terms of what we now use as Z-scores, because you know, they're ingrained into the programs that we use. And I'm sure most programs have a set of ingrained Z-scores. There is, by the way, for this audience, there is a website called Parameters, Paramaters, with a Z after it, Parameters.
I use that all the time, Norm.
Yes, and but look, we're talking to 200 people who may not have this, that are situated in areas where they don't have Z-scores incorporated. And the Z-score, Parameter Z, is a wonderful program, and it allows you to look at where the Z-score is, of which a Z is one Z is a 1 standard deviation beyond the mean. 2 Z's is 2 standard deviations beyond the mean. So you can see whether your ventricles or the dimensions that you're making are within the normal Z-score range, or whether they're out. So you may have a heart where the Z-score is minus 1.7 for the left ventricle and plus 1.5 for the right ventricle. That's going to give you disproportion. But, you know, they are both, it's still abnormal, but within the normal range. So those kind of things are really very helpful in terms of understanding. And as Mark had pointed out, I think it's not just one particular measurement, but it's a group of measurements. For example, for the isthmus of the aorta in determining coarctation, this was found on a recent study by my colleague, Dr. Anita Moon-Grady, to be significant when this value gets to be very low, that this is really indicative of a coarctation. So Z-scores are very, very important in terms of understanding and assessing fetal cardiac exams.
But don't we say basically that the RV is dominant until certain weeks of gestation?
I mean, you could say what you like.
I'm saying at back of our brain, we're thinking, oh, this is dominant because it's okay. Because this is, I think, a pitfall that we can miss. I think, as you said, go always for the Z-scores, but and then the mitral and the tricuspid valve ratios in the perhaps are going to be helpful.
I just was at another seminar yesterday where they showed a small right ventricle. And the problem was that the right ventricle wasn't receiving any blood. And when the surgery was directed towards changing the abnormality that reduced that, the right ventricle grew. And we do have to understand that the ventricles are and dimensions sometimes reflect the amount of flow going through them, and that this is not just a rigid chamber, but that it's dynamic and can change all of its measurements.
Thank you. And also, Susan, you've said a beautiful presentation, and you have proposed two things that are really useful, the abbreviations. Can you tell us what, and you said it costs money, where you want to screen all newborns for heart disease in collaboration and all that. I find it difficult, and I'm not sure, I mean, do you do it in your center?
No, not yet, but I think we have a very low threshold to screen newborns if they have any heart murmur or if they have any evidence of desaturation. We are in the process of collecting these data in comparison of how many echoes newborns in our center receives. But the most important, actually, the initial proposal, which is the mini fetal echocardiography screen, that actually can be performed by our OB and MFM teams, whoever see the patient first, which is going to overcome the still images present in the guidelines rather than waiting for the guidelines to be updated. So this is something important to happen, maybe during the routine 20-week gestation, which will cost no money, just extra time to get the clips and evaluation.
Mark, what do you think? Mark, do you agree?
Oh,
I agree. I'm sorry, go Norm.
No, I sort of agree that one should have a low threshold. I think we should be following all patients that we see with fetal abnormalities after they're born as well. And I think that's how you get to see the study like the one that came from Paris, where even if it went to autopsy, that they would get an idea whether they were right or wrong, or how right and how wrong they were. But I think that this becomes a matter of expense, and everybody's got tight budgets today in the United States and around the world as well. So that, you know, the idea of doing a screening on everybody is great. And I mean, you could even take that to getting MRIs on everybody, but there aren't enough MRI machines in the world to do a complete study like this, and it's an expensive test. And who's going to bear the expense of this test? That's
the important point.
You have to ask, you know, because in the ideal world where everything is free and it doesn't cost money and it's an endless resource, that's easy to do, but that's not the world that we live in today, unfortunately.
Yeah, I agree. I agree with everything that's being said. I think we should focus on improving prenatal screening for the reasons we talked about. Of course, after birth, if there's something abnormal, some concerning, that's a different thing. But in the fetus, for even a perfectly normal appearing fetus, needs to be screened, have detailed fetal cardiac screening too. So I think that's where we should focus a lot of our attention, although it's not exclusively there.
I think agree. Fetal screening is important. But Susan, what about the postnatal, the pulse oximeter? Don't you do pulse oximeter in a newborn nursery?
It's a routine. It has been implemented for many years.
Probably that will pick up some serious ones.
Not all. The problem is we are talking about improvement, and none of these modalities brings 100% detection rate. So.
Yeah.
Okay, I think we can close now.
Yeah.
Mark, Dr. Silverman, do you want to say anything?
I just think, yeah, I agree with you. I think these have been phenomenal talks. And I think all of the speakers, including Dr. Pavandi, who's had to go somewhere else, need to be congratulated for their perspectives and for providing us, the members of the Congenital Heart Academy, and I speak now for all of the participants as well, with a remarkable morning of education.
I'd like to thank everybody. Thank you all, but also would like to remind ourselves and the audience that this talk is going to be on the YouTube, and you can always watch it whenever you want. Also, and these fetal webinars by the Congenital Heart Academy will continue, and the next one is going to be in March 25th, and it's going to be hopefully by the Brazilian group to present interesting fetal cases and talks. Thank you again, and I'd like to thank all the speakers, Sasha and Grace. She's on holidays. I would like to thank Dr. Silverman for his time and his advice. It's always a pleasure to have Dr. Silverman on board. And see you soon. And tomorrow, I think Sasha is saying that there is going to be a beautiful class by Dr. Anderson.
Dr. Anderson is going to be talking tomorrow with Dr. Diane Spicer about what do you call the hole in the two ventricular chambers in single ventricle. Is it a VSD? Is it an interventricular communication? And what Dr. Anderson has done, and I attend all of his sessions, is he has taken us back and given us an insight into the embryology, which is absolutely unique. He has synthesized data from three-dimensional reconstructions through the various Sphetus horizon stages, has got scanning electron microscopes, has got three-dimensional data sets that he's cut in different ways. And it's really the most remarkable session that I've had the privilege of attending. So if you haven't been to that tomorrow morning, and every fetal echocardiographer must be interested in embryology because it's just one little stone throw away from where they're looking, you should attend this session. Thank you.
Thank you, Norm. Sasha, do you want to conclude?
Thank you very much. I think that we learn a lot from these different perspectives, and according to what is your idea, we are going down slowly in the world of fetal, because mostly of the things are new, probably for the new world, for the new approach to the congenital heart disease. So the opportunity that you are giving to the people to make it happen, to make such a big information, I'm sure will help all over the world. Every time with Norman, we say how many people will reach. And I'm very happy when we saw people from all around the world that this afternoon, more than 200 people plus YouTube channel, we will be able to share and improve the level of assistance for this.
We have plenty of people watching our webinar series, the fetal ones, around maybe the last one was 1,800 people watching the last one. So I'd like to thank the Congenital Heart Academy for doing a good job.
Well, there's
So
just
thank you very much. See you tomorrow. Bye, Norman. See you tomorrow.
There's one important point, and that's that we say there are 200 people watching, but there are many people that cannot watch because of time constraints. And this is, and you'll see them on the YouTube channel. You go to YouTube, the YouTube channel, and you go to videos, and you'll see all of the talks there. And also you will see a count of how many people have watched the session offline. And when there are 200 people that have seen this here, it's likely that there will be over 1,000 people in the next few days that will have seen this this talk. So the Congenital Heart Academy has done a wonderful job, and Sasha, you have to be congratulated for organizing this and minding the whole thing. Thank you and goodbye.
Thank you very much. Thank you. See you tomorrow. See you soon. Thanks, Rima. We wait for you next month.